So today's class is on rheumatology and it will be taken by Dr. Varun Pushkarna. So, sir, you can take over the class.
Yeah, thank you. So basically, rheumatology is a very important topic, and most of the times people don't pay attention to it, and it is simply thought of as either rheumatoid arthritis or maybe SLE, and then it is left to that only. But it is a vast topic, and you will get around 15 questions in the exam from rheumatology. Out of 200, 15 questions is a big number. And then there are certain drugs, pharmacology, which is also associated with rheumatology. Hence, these questions can also come under the same banner, but differently. Third, immunology also is considered as a outshoot of rheumatology. So the basic sciences, clinical sciences, you will get few questions aligned to rheumatology from these topics. So I have a question for all the contestants, all the students here who are appearing for MRCP. Do you want it to be a theory-based intensive class, or do you want it as a class which gives you a fair amount of idea with a lot of MCQs? Because I can switch over to both modes. Once we begin in one, we will continue in that only. I have no idea of your preparation level, so you can freely tell me in the box as to how do you want the class to be, and we will take it like that. Okay. So you want MCQs? Everybody is okay with that? Great.
Yes, sir.
Okay. So in any case, if you, yeah, okay, great. Somebody has very nicely mentioned if it is feasible to start with the theory topic and then discuss MCQs. Okay, fine, we can do that as well. So let us begin with rheumatology, and I always believe that rheumatology can be a boring topic, but we can make it interesting by sticking to the more interesting issues initially, and then we cover everything else. So the big king of rheumatology, rheumatoid arthritis, it is a chronic autoimmune disorder. So what is autoimmune disorder? Where the immunity has gone bad. It is basically our own immunity which is attacking the organs of the body by a phenomena either known as antigenic mimicry, that is some other organisms mimicking the same antigens that we have. So in an attempt to kill those organisms, body starts killing itself. One is mimicry, the other is hidden antigen concept. So some antigens, like for example, the DNA is inside the cell, inside the nucleus, and there it is DNA. Imagine this DNA comes out and is exposed to the circulating blood, then anti-DS DNA antibodies will be formed, which are hallmark of autoimmune disorders. So this is how the autoimmunity triggers. Now, what is wrong in rheumatoid arthritis? It is also autoimmune disorder, but it primarily affects the joints. Now, when I say primarily affects the joints, that means it's not the joints only that are involved. Other organs may also be involved, but mostly it is the joints that are involved, resulting in an inflammatory synovitis. Now, there is a difference between arthralgia and arthritis. So when it is only pain, it is arthralgia. When there is swelling, pain, stiffness, it is arthritis. Or in better still terms, it is called synovitis. Why? This is the bone, this is the bone. Here is the joint synovial capsule. This gets inflamed. Why? Because there is a debris inside which is triggering the inflammation, and this inflammation is actually eating out the cartilage that is there on the tip of the bone. Now, this cartilage damage leads to deformity of the joints eventually. Hence, rheumatoid arthritis becomes a very, very important diagnosis and a matter of debate whenever it comes to rheumatology. It is usually more common in women, young 30 to 50 years productive age group of body of life. And it is important from MRCP that they have been asking this question many times now, that what is a preventable risk factor? All a question will come that a 30-year-old female has come with polyarthritis, complaining of pains in multiple joints of the hands and feet since 3 months, and they will tell you a silence, and they will tell you a story about it, and then they will ask what is the most pertinent advice in lifestyle change that you will give to this patient. The answer is quit smoking, as simple as that. So basic questions can come from rheumatology, nothing to do with the pathophysiology, nothing to do with the drugs, nothing to do with the presentation, just the preventive aspect of it. What you can do is quit smoking. Now going on to the pathogenesis, so both T cells and B cells are at fault. There is a proper response from both of these lineages, immune lineages, leading to damage of the synovial cartilage. There is a very well-known concept of interferon gamma attacking the cells, activating the macrophages and attacking the synovial cells and damaging it to the core. Interleukin 17, synovial plasma cells producing antibodies against self-antigens like citrullinated peptides. Now, this question has come in the exam, as basic as that, that in the pathophysiology, which of the following are true and false? So it is not the WBCs circulating which are making these antibodies. It is the synovial plasma cells which are in the synovial fluid. These synovial plasma cells are the ones that make the most famous anti-CCP antibodies, that is citrullinated peptides. The HLA association is there. HLA association means some people are genetically predisposed to develop rheumatoid arthritis. How do we define those patients? These are those patients who have congenitally inherited HLA-DR4 gene in their body system. Associated conditions or syndromes are Felty's syndrome, where rheumatoid arthritis presents with TLC of around 2000. There is neutropenia with around, so this will be like 20% polymorphs and 60 or 80% lymphocytes. So this can be the picture, and rheumatoid arthritis can present with neutropenia along with splenomegaly. So this is Felty's disease or Felty's syndrome. Then there is Kaplan syndrome, which is found in poll workers. So whenever there is a history of coal work associated with and rheumatoid arthritis, and they give you that there are multiple nodules in the lungs, this is Kaplan's syndrome. Factors of poor prognosis are when males have it, when it is slow to originate, and when it originates late in the life. There are, and then anti-CCP has higher value of anti-CCP.
Sir, can you repeat that poor prognosis factors?
Yes. Male gender, slow onset of disease, late onset of disease, presence of anti-CCP antibodies, and when number of joints involved is more than 5. So these 5 features, they indicate the poor prognosis. When it presents in males, when it presents late onset, when it late on, and when it is slow to progress. Slower the rheumatoid arthritis, worse it is. Why? Because one is that the patient will come to you late. Second, the disease would have progressed by then. So if it progresses fast enough, the patient will come to you early. You will treat the patient early. So male gender, late age of onset, slow to progress, where anti-CCP levels are higher than rheumatoid factor, when the number of joints involved are more than 5. These are the poor prognosis. Clinical features, of course, all of these patients are fatigued. This is the first and foremost sign of 99% of autoimmune disorders. Then morning stiffness that lasts more than 1 hour. 30 minutes is also fine, but then it has to be a perfect, that is association, that is it has to be present daily. Pain, stiffness, swelling. This defines synovitis. That is arthritis. Which joints? So it is the metacarpophalangeal joints and proximal interphalangeal joints. Remember, if it is affecting the distal joints, it is anything else but rheumatoid arthritis. So whenever in the question paper you see DIP is involved, it is not rheumatoid arthritis. Not that it cannot exist in the open market, like the patients that come, they can have. But why? Because rheumatoid arthritis and osteoarthritis both can present in the same patient. But that is a far-fetched idea for an exam. For as a dictum, distal interphalangeal joints cannot be involved in rheumatoid arthritis. It is a dictum. It is a medical dictum. If it is not that, if the distal joints are involved, it is either osteoarthritis or psoriatic arthritis or ankylosing spondylitis with peripheral involvement, but it is not rheumatoid arthritis. Mark it, underline it. If the distal interphalangeal joints are involved, the patient has rheumatoid arthritis. And of course, metatarsophalangeal joints involvement. Okay. Then all these patients, they have chronic anemia of chronic disease, they have weight loss, decreased grip strength. So there is a test known as hand squeeze test. Anybody knows about this test? So basically what happens, you just shake the hand with the patient and the handshake should be firm enough. So that will trigger the pain so much that the patient will withdraw their hands. This is classical test positive for rheumatoid arthritis. Of course, they will also have a weak grip strength at the same time. Subcutaneous nodules. Remember, subcutaneous nodules are having very less differential diagnosis. One is rheumatoid arthritis. Anybody else can tell me something else? Subcutaneous nodules in the medical literature where MCQs are involved, where do you all see other example of subcutaneous nodules?
Infective endocarditis.
Where it is asked in the exams?
Erythema nodosum.
Say again.
Fever.
Infective endocarditis.
Infective endocarditis.
Infective endocarditis or
Rheumatic fever.
or rheumatoid arthritis or rheumatic fever.
Yeah, rheumatic fever.
Rheumatic fever.
Yeah. So rheumatic fever, subcutaneous nodules are prominent feature there. Splenomegaly, ulnar deviation of the fingers, swan neck deformity. These are some things that you have already been studying, these deformities throughout your MBBS and cramming them up for NEET PG. But these are not usually asked in the MRCP exam. More important things like the involvement of DIP, hand squeeze test, poor prognosis, true and false, they will be asked. On imaging, see, X-ray, not many people are ordering for rheumatoid arthritis. It is a very important test. Why? Because you can see erosive nature of this arthritis. Although it is not as erosive as psoriatic arthritis is, psoriatic arthritis is so erosive that it is known as arthritis mutilans. It literally destroys the joints. But rheumatoid arthritis also has a significant element of erosive arthritis. Particularly bony erosions are there. They are hallmarks. There is diffuse osteopenia. You can make out that the bone is literally weak. It is not as radio opaque as it should be. Joint space narrowing will be there in the carpal, metacarpal, and phalangeal, interphalangeal joints. Ulnar deviation you can see on the X-rays. And in the laboratory tests, it is important that RA factor should be done, or rheumatoid factor should be done. This question is very important for MRCP. What is a rheumatoid factor? It basically is an IgM antibody. So, if something is an IgM antibody, can it cross placenta? Can it cross placenta?
No, sir.
No, sir.
No. Very good. So IgM is a big antibody. It cannot cross placenta. And the irony of the matter is that this is an antibody against antibody only. So it is IgM antibody against IgG.
FC portion.
What IgG? It's FC portion. Yes. So it is an antibody which is targeted against a subset of immunoglobulin G. Okay. So this is a missile against a missile. It is not against a particular organ. That is why the inflammation is so profound in case of rheumatoid arthritis, because already there is an IgG formed and this IgM is against that antibody. And normally what happens in, like we read in vaccinations, that initially it is IgM, which then converts to seroconversion happens, and it eventually converts to IgG, isn't it? But here, rheumatoid arthritis is one unique situation where throughout life, the IgM does not convert to IgG. It remains IgM. Is that clear? Normally, like in chicken pox, we see, okay, IgM is initially positive, then it becomes IgG. In HIV, HCV, hepatitis B, it is IgM to begin with and IgG later on. Because IgM, we know, it goes up and then comes down. IgG becomes like this and then remains positive all the life. Here, IgM remains positive all the life because of multifactorial, multi-plasma cell triggering. Is that okay? Understood? Okay. So this was rheumatoid factor. Then comes anti-CCP antibody, much specific, much specific. Let us say somebody has symptoms, but rheumatoid factor is negative. But symptoms are very typical. The next investigation is anti-CCP. Why? If anti-CCP is negative, the chances are this patient may have SLE, may have chikungunya, may have anything else, but not rheumatoid arthritis. But if it is positive, then the patient certainly has rheumatoid arthritis. Is that clear? So rheumatoid factor is important, but anti-CCP is much more specific. It may not be as sensitive. So it's not important. It's not necessary that it become positive. But if it is positive, it is not anything. Sorry, I had to take that call. So anti-CCP is much more specific than rheumatoid factor. For rheumatoid arthritis, rheumatoid factor can be found in any diseases, even in viral fever, sometimes it comes positive. The anti-CCP can predict eventual development into rheumatoid arthritis when found in undifferentiated arthritis. So when a disease is less than 3 months, you cannot label it as rheumatoid arthritis, so you call it undifferentiated arthritis. So if anti-CCP is positive before 3 months, I mean the patient comes to you within 3 months of onset of symptoms, you cannot call it rheumatoid arthritis. By EULA definition, somebody has to have more than 3 months of symptoms. But let us say they have come to you within 3 months and you tested them, anti-CCP is positive. Right now, the patient is undifferentiated arthritis. Why? Because the duration is less than 3 months. But if anti-CCP is positive, there are chances, high probability that this patient will develop full-blown rheumatoid arthritis. Why? Because this anti-CCP, as I told you, this is an antibody which is produced by the synovial plasma cells. So if it is being released right there and then, it is high probability that the joint will be eaten up. Hence, this is an important marker of erosive disease. It may be detected in healthy individuals much earlier than the diagnosis is made. Sometimes patients are totally asymptomatic, but because of their fatigue, because of their tiredness, sometimes people tend to get their anti-CCP levels done. And when they are positive, they can predict even 10 years in advance that this patient can go on to develop rheumatoid arthritis clinically. It is better than rheumatoid factor for diagnosis. Why? Because anti-CCP will not be positive in SLE. Anti-CCP will not be positive in Sjögren's syndrome. Anti-CCP will not certainly be present in scleroderma, but rheumatoid factor can be positive there. Okay. Important is that the levels of anti-CCP will not fluctuate with disease activity. So even if you give steroids, put the patient into remission, the anti-CCP levels will not rise or fall. However, rheumatoid factors can rise or fall with treatment. Increased ESR and CRP is the universal finding in all the inflammatory disorders. So they will be there. Main differential features differential diagnosis will be SLE, psoriatic arthritis, osteoarthritis, viral arthritis of parvo B19, or chikungunya. Treatment, very important, smoking cessation. Initially, the treatment is non-steroidal drugs and steroids, but eventually these patients will be required disease-modifying anti-rheumatoid drugs as soon as the rheumatoid arthritis is diagnosed. DMARDs, for example, methotrexate is the king of DMARDs. Hence, many questions in MRCP, rheumatology, pharmacology will be addressed to methotrexate. DMARD of choice acts as a folic acid antagonist. Side effects are GI. Not many people tolerate it. Oral ulcers can occur. Stomatitis happens. Macrocytic anemia. Why? Because the same pathway is folic acid pathway, which is inhibited, and hepatotoxicity. Very important that you continue to repeat SGOT-PT. By EULAR guidelines, it is 15 days, every 15 days for first 3 months, and then every 6 months. You need to repeat the transaminases levels, SGOT, SGPT, every 15 days initially, and then higher on. So, another drug which is very important is leflunomide. Again, very, 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 very hepatotoxic. So, monitoring of liver enzymes is very important. Sulfasalazine, time-tested anti-inflammatory painkiller, also can be classified under non-steroidals and DMARDs, both. Very good drug, lesser used because lesser tolerated. Hydroxychloroquine, usually the second drug in line after methotrexate. So this is the usual combination that most of the patients they take. Eventually, these patients may require azathioprine. I will give you a situation just in a moment. How DMARDs help? They improve the symptoms. Symptomatic relief is there. The number of joints involved decrease. Definitely decrease. This is an MRCP true and false question. They reduce the inflammatory markers like ESR and CRP. They slow down the radiological injury. They slow down the disease progress. And they also correct the anemia of chronic disease. Okay. Now, I have a question for you all. A lady wants to conceive. She has rheumatoid arthritis and she has been on methotrexate. Because methotrexate is a it can be used as an infertility agent. It can make the person infertile because of folic acid pathway inhibition. And the problem is the patient is symptomatic. So you have stopped methotrexate. What is the drug that can be used in rheumatoid arthritis patient during pregnancy?
Sulfasalazine and hydroxychloroquine.
Azathioprine.
Wonderful. Azathioprine is the answer. So azathioprine has no labeled contraindication in pregnancy. Hydroxychloroquine has, sulfasalazine has, leflunomide has, methotrexate has. So there should not be any confusion in your mind that if a pregnant patient comes to you in the exam as a patient of rheumatoid arthritis, then the answer will be azathioprine. Okay?